Again, it's an honor to be here, and I see Dr. Roberts' name on the panelist list, and especially being in front of him, in front of her, sharing this fibroid talk is very nerve-wracking, but I'm going to do my best. And I hope you're hearing me and seeing my screen well, and feel free to ask me any questions during or after the presentation. I don't have any disclosures. Second, all right. Uterine fibroids, also known as uterine myomas, are the most common solid pelvic tumor in women, and up to 40% of women affected during uterine fibroids during their reproductive years, and the fibroid prevalence in some studies as high as 70% in Caucasian women, and it can go up to 8% in Black women. And there are different ways of categorizing uterine fibroids. Traditionally, fibroids have been described on their according to their location, being in submucosal, intramural, or subserosal. But recently, we've been describing the fibroids according to their submucosal location percentage, and the intramural percentage, and if they are pedunculated, or they are myometrial or non-myometrial. So I highly recommend reading this article, and if you're interested in learning about this subgroup classification. The patients may present with different symptoms, and most of the patients present with no symptoms. And the fibroids are found incidentally during their lumbar spine workup or during their gynecologic exams. And when they present with symptoms, these could be bleeding, box symptoms, or pain. When we say bleeding, the menstrual bleeding could be more than 7 days, and patients may have to change their feminine products every hour, every 2 hours. So we ask them how many times do they change, and how long their periods are. And the box symptoms are usually presented as the abdominal pressure feeling, any urinary problems, or bowel dysfunction. And most patients have pain during their periods. Sometimes they start 2 days before, and these pain can radiate to the back. And in some patients, I heard that they are having leg pain during their periods. We discuss every treatment options with the patients. These include medical treatment, surgical, or minimally invasive. And it's an interactive discussion between gynecologists, interventional radiologists, and the patient. And in some cases, medical therapy can be sufficient, and some patients would like to keep their uterus, and some patients are, no, I don't want any periods anymore. I want my uterus to be out. So it's very important to offer every type of treatment to our patients, and just decide all together what's best for them. And most of the time, I work in Kentucky, and there are rural parts of Kentucky that people don't know anything about interventional radiology or uterine fibroid embolization, and the only option they're offered are hysterectomy. And we're trying hard to give the option and teach people what interventional radiology is and what we can offer. Differential diagnosis is very, very important, and we need to rule out any abdominal tumors, any infection, endometriosis, adenomyosis, or other causes like GI causes. And sometimes these can overlap with each other, so we may need to touch base with our gastroenterology colleagues as well. I would like to describe chronic pelvic pain because these patients can suffer from pain for long times. The chronic pelvic pain is described of presence of pain longer than 6 months, and this chronic pelvic pain is responsible for 30% of the outpatient gynecologic visits in the United States. And as interventional radiologists, we offer uterine fibroid embolization for our patients. And this procedure was first described in 1995. The workup is like every interventional radiology procedure. We check the labs for specific to interventional radiology. We would like to get a pelvic MRI and pap smear. And for patients over 40 years old who are presenting with bleeding presentation, we get endometrial biopsy in our clinic. And contraindications are pregnancy, cancer. If the fibroids are already infarcted and patients are starting having less symptoms, then we do not offer the procedure unless there is a strong indication that there are other fibroids that are causing problems. And if there is any submucosal fibroid, and in addition to intramural fibroids, we talk to our gynecologists, and we can do uterine fibroid embolization after intracavitary fibroid removal. Sorry. And the uterine artery is a branch or anterior division of the internal iliac artery, which arises below the obturator artery. And it has a ascending, transverse, and descending branch. And it courses an inferior part of the broad ligament of the uterus. And before the procedure, we get a serum pregnancy test from our patients. We place a Foley catheter because bladder and uterus are very close to each other. We don't want the contrast in the bladder to decrease our image quality, and it just gives a better image and patients are more comfortable. We make sure patients are hydrated, and we give prophylactic antibiotics, antiemetics, and pain medications. And in my department, we consult our pain team. They set up the PCA pump, and we admit our patients overnight, and we watch their pain and nausea. The procedure can be performed from femoral access or radial access, and I prefer the femoral access. And if there are any cases that patients prefer radial access, we can offer that too. But in our rooms are not prepared for left side procedures a lot. That's why the technologists and everyone gets very confused with the left side access sometimes. So I use Robert's uterine catheter to catheterize the contralateral uterine artery, and then the right-sided internal iliac artery. And after, before every procedure, we do before every uterine artery catheterization, we do a pelvic angiogram. And after embolization, I repeat the pelvic angiogram to check if there is any ovarian contributors. And we use particles. In my institution, we use 500 to 700 embospheres, and followed by 700 to 900 embospheres. And we watch the injection under fluoroscopy to avoid any reflex or non-target embolization. And for radial artery access, we do a Ellen or Barbo test prior to the procedure. We measure the diameter of the vessel, and we inject a cocktail before and after the procedure. About 10% of the patients who has uterine fibroids may have ovarian artery contributors, and we after the embolization, when we check the pelvic uterine artery, if the uterus is completely embolized or not, you can see ovarian artery contributors. And this is a case that the patient didn't have any uterine arteries, and both both-sided uterus was fed by ovarian arteries, and we embolized ovarian artery, and the patient didn't have any any problems after the procedure. The uterine fibroid embolization is a low risk procedure, and most of the time, 15 to 30% of the patients may have post-embolization syndrome. These patients present with pain, low-grade fever, and leukocytosis, and this should be differentiated from infection. And we discuss our expectations with the patients before the procedure. For sure, improvement in heavy bleeding in 2 cycles is the most expected outcome. But bulk symptoms can take more time as the uterus needs time to shrink. And in my experience, patients have resolved bloating and pressure feeling within a couple of weeks. And the follow-up is in my institution, we do a 6-week follow-up and a 6-month follow-up with pelvic MRI, and our gynecology partners continue follow up our patients. And this is an example of a 6-month follow-up. You can see significantly decreased size of the uterus, and the solid nature of the uterus is now cystic, and patients describe no pain, resolved bleeding problems, and significantly increased quality of life. And during this procedure, we can also use a superior hypogastric block to decrease the pain. And in these cases, we use fluoroscopy and insert a needle into the superior hypogastric plexus and inject a cocktail to decrease the pain during and after the procedure. And this is if I can give one article during this presentation, I know I don't have a lot of time. I think this is a good article for you to read from CVIR. And this study concluded that uterine artery embolization is a less invasive procedure compared to myomectomy, which is equally effective and safe as myomectomy. But myomectomy appears to have superior reproductive outcomes in the first 2 years after treatment. Thank you very much.